of a patient is a set of information the physicians collect over medical interviews. It involves the patient, and eventually people close to them, so to collect reliable/objective information for managing the medical diagnosis and proposing efficient medical treatments. The medically relevant complaints reported by the patient or others familiar with the patient are referred to as symptoms, in contrast with clinical signs, which are ascertained by direct examination on the part of medical personnel. Most health encounters will result in some form of history being taken. Medical histories vary in their depth and focus. For example, an ambulance paramedic would typically limit their history to important details, such as name, history of presenting complaint, allergies, etc. In contrast, a psychiatric history is frequently lengthy and in-depth, as many details about the patient's life are relevant to formulating a management plan for a psychiatric illness. The information obtained in this way, together with the physical examination, enables the physician and other health professionals to form a diagnosis and treatment plan. If a diagnosis cannot be made, a provisional diagnosis may be formulated, and other possibilities, the differential diagnoses, may be added, listed in order of likelihood by convention. The treatment plan may then include further investigations to clarify the diagnosis. The method by which doctors gather information about a patient's past and present medical condition in order to make informed clinical decisions is called the history and physical, aka the H&P. The history requires that a clinician be skilled in asking appropriate and relevant questions that can provide them with some insight as to what the patient may be experiencing. The standardized format for the history starts with the chief concern, why is the patient in the clinic or hospital, followed by the history of present illness, to characterize the nature of the symptom, S, or concern, S, the past medical history, the past surgical history, the family history, the social history, their medications, their allergies, and a review of systems, where a comprehensive inquiry of symptoms potentially affecting the rest of the body is briefly performed to ensure nothing serious has been missed. After all of the important history questions have been asked, a focused physical exam, meaning one that only involves what is relevant to the chief concern, is usually done. Based on the information obtained from the H&P, lab and imaging tests are ordered and medical or surgical treatment is administered as necessary. Process. A practitioner typically asks questions to obtain the following information about the patient. Identification and demographics, name, age, height, weight. The chief complaint, CC, the major health problem or concern, and its time course, e.g. chest pain for past 4 hours. History of the present illness, HPI, details about the complaints, enumerated in the CC, also often called history of presenting complaint or HPC. Past medical history, PMH, including major illnesses, any previous surgery/operations, sometimes distinguished as past surgical history or PSH, any current ongoing illness, e.g. diabetes. Review of systems, ROS, systematic questioning about different organ systems. Family diseases, especially those relevant to the patient's chief complaint. Childhood diseases, this is very important in pediatrics. Social history, medicine, including living arrangements, occupation, marital status, number of children, drug use, including tobacco, alcohol, other recreational drug use, recent foreign travel, and exposure to environmental pathogens through recreational activities or pets. Regular and acute medications, including those prescribed by doctors, and others obtained over the counter or alternative medicine. Allergies, to medications, food, latex, and other environmental factors. Sexual history, obstetric/gynecological history, and so on, as appropriate. Conclusion and closure. History taking may be comprehensive history taking, a fixed and extensive set of questions are asked, as practiced only by healthcare students such as medical students, physician assistant students, or nurse practitioner students, or iterative hypothesis testing, questions are limited and adapted to rule in or out likely diagnoses based on information already obtained, as practiced by busy clinicians. Computerized history taking could be an integral part of clinical decision support systems. A follow-up procedure is initiated at the onset of the illness to record details of future progress and results after treatment or discharge. This is known as a catamnesis in medical terms. Review of systems. Whatever system a specific condition may seem restricted to, all the other systems are usually reviewed in a comprehensive history. The review of systems often includes all the main systems in the body that may provide an opportunity to mention symptoms or concerns that the individual may have failed to mention in the history. Healthcare professionals may structure the review of systems as follows. Cardiovascular system, chest pain, dyspnea, ankle swelling, palpitations, are the most important symptoms, and you can ask for a brief description for each of the positive symptoms. Respiratory system, cough, hemoptysis, epistaxis, wheezing, pain localized to the chest that might increase with inspiration or expiration. Gastrointestinal system, change in weight, flatulence and heartburn, dysphagia, odynophagia, hematmesis, melena, hematochezia, abdominal pain, vomiting, bowel habit. Genitourinary system, frequency in urination, pain with micturition, dysuria, urine color, any urethral discharge, altered bladder control like urgency in urination or incontinence, menstruation, and sexual activity. Nervous system, headache, loss of consciousness, dizziness, and vertigo, speech and related functions like reading and writing skills and memory. Cranial nerve symptoms, vision, amaurosis, diplopia, facial numbness, deafness, oropharyngeal dysphagia, limb motor or sensory symptoms and loss of coordination. Endocrine system, weight loss, polydipsia, polyuria, increased appetite, polyphagia, and irritability. Musculoskeletal system, any bone or joint pain accompanied by joint swelling or tenderness, aggravating and relieving factors for the pain and any positive family history for joint disease. Skin, any skin rash, recent change in cosmetics and the use of sunscreen creams when exposed to sun. Inhibiting factors. Factors that inhibit taking a proper medical history include a physical inability of the patient to communicate with the physician, such as unconsciousness and communication disorders. In such cases, it may be necessary to record such information that may be gained from other people who know the patient. In medical terms, this is known as a hetanamnesis, or collateral history, in contrast to a self-reporting anamnesis. Medical history taking may also be impaired by various factors impeding a proper doctor-patient relationship, such as transitions to physicians that are unfamiliar to the patient. History taking of issues related to sexual or reproductive medicine may be inhibited by a reluctance of the patient to disclose intimate or uncomfortable information. Even if such an issue is on the patient's mind, they often do not start talking about such an issue without the physician initiating the subject by a specific question about sexual or reproductive health. Some familiarity with the doctor generally makes it easier for patients to talk about intimate issues such as sexual subjects, but for some patients, a very high degree of familiarity may make the patient reluctant to reveal such intimate issues. When visiting a health provider about sexual issues, having both partners of a couple present is often necessary, and is typically a good thing, but may also prevent the disclosure of certain subjects, and, according to one report, increases the stress level. Computer-assisted history taking. Computer-assisted history taking or computerized history taking systems have been available since the 1960s. However, their use remains variable across healthcare delivery systems. One advantage of using computerized systems as an auxiliary or even primary source of medically related information is that patients may be less susceptible to social desirability bias. For example, patients may be more likely to report that they have engaged in unhealthy lifestyle behaviors. Another advantage of using computerized systems is that they allow easy and high-fidelity portability to a patient's electronic medical record. One disadvantage of many computerized medical history systems is that they cannot detect nonverbal communication, which may be useful for elucidating anxieties and treatment plans. Another disadvantage is that people may feel less comfortable communicating with a computer as opposed to a human. In a sexual history-taking setting in Australia using a computer-assisted self-interview, 51% of people were very comfortable with it, 35% were comfortable with it, and 14% were either uncomfortable or very uncomfortable with it. The evidence for or against computer-assisted history-taking systems is sparse. As of 2011, there were no randomized control trials comparing computer-assisted versus traditional oral and written family history taking to identifying patients with an elevated risk of developing type 2 diabetes mellitus. In 2021, a substudy of a large prospective cohort trial showed that a majority, 70%, of patients with acute chest pain could, with computerized history taking, provide sufficient data for risk stratification with a well-established risk score, HEART score. A medical history typically follows the history of the present illness if obtained by the treating clinician. The medical history can reveal diagnosed medical conditions, past medical conditions, and potential future health risks for the patient. In addition, the medical history aids in forming differential diagnoses. A comprehensive history intake includes the patient's medical history, past surgical history, family medical history, social history, allergies, and medications. Within graduate education, the order of obtaining medical history generally follows the format below. However, with clinical experience, the clinician may follow a more colloquial, natural flow to the clinical intake. Some areas are omitted or expanded depending on the purpose of the medical history and healthcare setting. Some aspects of the medical history are standardized to arrive at an accurate differential diagnosis, leading to optimal patient outcomes. Members of the interprofessional team contribute to each aspect of the medical history intake. This topic is intended for students and practicing clinicians who adhere to the medical practices commonly employed in the United States. Medical and surgical history. A way to rephrase the question is to inquire about medical conditions diagnosed or medical conditions for which a patient takes medications. If the patient has no previous diagnoses, asking about surgeries is another approach. For example, in the case of a patient who underwent bariatric surgery, the patient is likely diagnosed with hyperlipidemia but does not consider this a medical disease. Alternatively, the patient might mention taking benzodiazepines, indicating a potential diagnosis of anxiety or major depressive disorder. For women patients, it is essential to inquire about any previous pregnancies, abortions, or miscarriages. Both aspects of the history are crucial for understanding the patient's risk factors, identifying contraindicated medications or treatments, and determining appropriate imaging modalities. Family history. Inquiring about the biological mother, father, and extended family helps clinicians understand the risk of cardiovascular disease, respiratory disease, or endocrine disorders, including coronary artery disease, chronic obstructive pulmonary disease, or diabetes. Family clinicians inquire more specifically into the history of myocardial infarctions, cancers, and psychiatric or neurological diseases to assess potential risk factors. For example, missing a genetic predisposition to Huntington's disease is considered an inadequate history. Several family history tools that integrate with electronic medical records are available to augment this history intake, some of which have succeeded. Social history. The inclusion of social history in medical management can vary depending on the clinician's values and the scope of their practice. Substances or nutrition. Inquiring about substance use in a neutral approach ensures a positive patient-clinician rapport. Some patients may consider substances a part of their approach to nutrition, which can be integrated into a comprehensive social history. Red wine, cannabis, and other legally available substances are a part of some diets, treatments for pain relief, or recreational use. Some recent rapid assessments provide a quick picture of nutritional health. When considering a diagnosis affecting appetite, inquiring about eating habits is pertinent. Travel history. Recent travel history could make or break a treatment plan for primary care, emergency medicine, or internal medicine clinicians. For example, failing to ask about travel could exclude a diagnosis of meningitis, a life-threatening disease. Similarly, Lyme disease caught at a late stage causes cardiovascular issues, which might be revealed by asking patients about recent hiking activities. Inquiring about geographic regions is essential for some infectious diseases. Sexual history. Intake varies due to conflicting values of clinicians about sexual lifestyle and behaviors. Remaining cognizant of gender-diverse, non-traditional sexual relationships is important. The current guidelines in the United States recommend the 5PS approach: partners, practices, protection from sexually transmitted infections, history of sexually transmitted infections, and prevention of pregnancy. Allergies and medications. Patient allergies are crucial to history gathering, as they may have potentially life-threatening consequences. Inquiring if the patient has any medication allergies and, if they do, clarifying any previous allergic reactions informs the development of a treatment plan. Medication history is also essential to mitigate the risk of drug-drug interactions. Several electronic medical record systems flag or alert clinicians for these interactions, which could be clarified during the clinical interview. Specialized history. Reproductive, depending on the chief complaint, age-appropriate questions about female patients' last menstrual period and pregnancy history, including gravidity and parity, may be asked. Further questions about menarche and menopause may also be appropriate. For example, if a sexually active female arrives complaining of lower abdominal pain, reproductive history is essential to rule out ectopic pregnancy. If the same patient is of menopausal age, such questions are inappropriate in this context. Pediatric, parents of infants should be asked about pregnancy, delivery, and prematurity complications. In addition, it is crucial to inquire about the immunization status and developmental milestones, since pediatricians are the primary clinicians until children reach adulthood. As such, staying attentive to familial relationships helps identify any signs of abuse. Geriatric, the immunization status of geriatric patients is often relevant. With more vaccination options, including the recently introduced COVID-19 series, this may become a standardized aspect of history taking. Medication interactions are also common and could be clarified during the clinical interview. Surgical. In surgical specialties and areas such as dermatology, cardiology, and gastroenterology, the outcome of previous surgeries determines the approach to future surgeries. A detailed history of these previous surgeries is vital for treatment planning, including the anatomical approach. Issues of concern. Biases in history taking. The following principles, originally derived from the approach to neurocritical patients, are applicable to all history intakes to address biases. Anchoring, focusing on one aspect of medical history when new information is available. Availability, based on available information, deeming a diagnosis more or less likely. Premature closure, narrowing on a diagnosis before completing a thorough workup. Representativeness restraint, forcing all history into one pattern of clinical presentation. Unpacking principle, focusing on some aspects of workup and omitting others before arriving at a diagnosis. Context errors, considering all parts of medical history equally relevant. The primary goal of obtaining a medical history from the patient is to understand the patient's state of health and determine whether the history is related. The secondary goal is to gather information to prevent potential harm to the patient during treatment. Focusing on these goals in the context of recognized biases and colleague feedback reduces diagnostic errors. Health literacy. A key concern is ensuring patients understand questions and can provide accurate histories based on their health literacy. Patients may not consider their illnesses relevant when asked about medical problems, especially in acute treatment settings. Sometimes, a question may be asked in multiple ways using colloquial rather than medical terms. When encountering language barriers, The best practice approach is to use the facility-provided language service but not limit the intake level. Clinicians have approaches to hand off between nurses, nurse practitioners, physician assistants, and physicians so that important aspects of history are communicated. Health Insurance and Portability and Accountability Act. Patients may withhold information due to fear of judgment or legal consequences. Patients should be reassured that the information is gathered to find the root cause of their illness and treat them most effectively and efficiently. Once obtained, this information must be handled with utmost care to ensure patients' privacy in accordance with laws such as the Health Insurance Portability and Accountability Act, HIPAA, in the United States. This law prohibits the unauthorized sharing of health information. Use of mobile applications and artificial intelligence. The use of mobile applications and artificial intelligence-driven programs is at the heart of current discussions regarding workflow. The results of current studies recommend that these tools enhance the workflow rather than substitute the clinician's role for conducting a standardized medical history. If the question set is too large, results demonstrate that the history does not accurately match the defined purpose, such as the patient's chief complaint. Clinical significance. The medical history is brief or expanded depending on the scope of a medical visit. If a patient presents for an annual wellness visit, the history should encompass all aspects of the patient's history. If the patient has an established relationship with the clinician or is arriving for a procedure such as cyst removal or pap smear, the history does not need to include all standardized aspects. In procedural, surgical, or progress visits, the medical history is more tailored to the visit. Focused history. A focused history is utilized in urgent care or emergency settings. Instead of extensively analyzing every detail of the patient's illness history, such as events that may have occurred years ago, the focus is on understanding the immediate context of the visit. This approach includes any changes that have occurred since the last visit and the long-term outlook. This approach is similar to the practice in some primary care visits, where the emphasis is placed on addressing the patient's immediate needs and providing timely care. For example, a patient with a history of breast cancer on chemotherapeutic drugs with a cough versus a healthy patient with no chronic disease. Although the clinician has access to the entire medical history, questions should remain focused on the chief complaint of cough and not delve into cancer management plans. Similarly, if a patient presents with altered mental status and can no longer provide a history, looking into previous admissions or speaking to the admitting team for relevant information is more appropriate. A detailed history may not be as relevant as the accident the patient just emerged from or a previous history of stroke. Clinicians tailor the physical examination to address aspects pertinent to the patient's clinical complaint and the focused history. For example, in cases of difficulty breathing and a history of asthma, emphasis is placed on conducting a thorough lung examination, possibly omitting other parts of the physical examination. Expanded history. Complete medical histories may be obtained after the patient has stabilized or if the patient presents for a visit requiring a thorough history. The family members or caregivers may be a potential source of information about a patient's medical history when the patient is unsure or unable to answer questions. The same patient in cancer treatment could be asked about changes in sleep, appetite, vaccination status, partners, or additional details to tailor a treatment plan, including changes in medication regimen and lifestyle recommendations. In such cases, the treating clinician may continue to discuss different treatment options. Some clinicians may consult with specialists to gain further medical insights and maintain continuity of care. Typically, a review of systems and physical examinations includes all systems, nursing, allied health, and interprofessional team interventions. Although obtaining a detailed history is crucial, it is equally important for clinicians to approach the questioning process with empathy and consideration for the patient's feelings and condition. Patients may feel rushed or uncomfortable if questions are asked in the same order using the exact words as learned during educational contexts. By adapting the questioning style to accommodate each patient's individual needs and preferences, clinicians can create a more comfortable and engaging environment for communication. This approach not only enhances the quality of information gathered but also enables clinicians to develop their values and skills in patient-centered care. Furthermore, effective communication of the patient's medical history to other healthcare professionals is essential for ensuring continuity of care and preventing medical errors. Hand-off protocols between healthcare teams serve as crucial checkpoints for transferring patient information accurately and comprehensively. Each healthcare facility has a standardized checklist, which may include reviewing key aspects of the patient's medical history, such as diagnosed conditions, past surgical procedures, and current medication lists. By adhering to these protocols, healthcare professionals can facilitate smooth transitions of care, minimize the risk of oversight or miscommunication, and ultimately promote better patient outcomes. Nursing, allied health, and interprofessional team monitoring. Various members of an interprofessional healthcare team, including technicians, nurses, advanced clinicians, physicians, and specialists, play integral roles in gathering different components of a patient's medical history. As each interprofessional team member is involved in coordinated care, communication is essential to ensure that the same intake is not repeated or that crucial pieces of the medical history are missed. Some aspects of the medical history are best obtained at triage, whereas the surgeon or pharmacist may more appropriately address other aspects. Understanding the scope of practice is crucial for conducting clinical intake effectively, leading to the next step in a medical visit. Thank you for watching this video.